Thank you everyone for joining us today for our fifth SMM webinar um, in our series, and we hope that you're able to join ones that we have later on this year. Okay, so if you haven't already, just go ahead and chat in your hospital name and organization, and you can also add in your role on the team. And this is just a brief overview of our agenda today. Welcome everyone. Dr. Lister will be giving us an overview on DIC. She'll be doing some SMM case reviews, and then we'll just have a few closing remarks and announcements. So before we get started, there will be some interactive portions of the meeting today. So if you just wouldn't care to go ahead and scan that QR code, or I'm going to add it in the chat for our Mentimeter, if that's just easier for you to click on that link. And you'll know when it's time to do one because the slide will pop up for it, and we'll be sure to announce it. We'll just have some questions thrown in there that'll kind of flow along with today's meeting. And our presenter today is Dr. Rolanda Lister. She is a maternal fetal medicine specialist at Vanderbilt University Medical Center, and she is also the TIP QC health officer. So thank you for presenting for us today, Dr. Lister.
Good afternoon, everyone. It's my pleasure to present on disseminated intravascular coagulation, a severe maternal morbidity indicator. Next slide, please. So today's learning objectives are to discuss the epidemiology of DIC, understand the definition, understand some of the underlying etiologies of DIC, most importantly, how to assess and ultimately treat patients who have DIC. And that goes into the management strategies. Next slide, please. So this is data taken from the Severe Maternal Morbidity Project, recently newly formed group that has looked at severe maternal morbidity. As we know, when we have a maternal death, we're probably very familiar with maternal mortality. And really, for every maternal death, there are up to 100 severe maternal morbidity incidences or near misses. So the thinking is if we can address severe maternal morbidity, then we can subsequently address severe maternal mortality. So ultimately, when you look at all of the cases of SMM that's determined by the ICD and ICD-10 codes that look at 21 specific SMM indicators, indicating that there was a much worse outcome or significant pregnancy complication. You can see hemorrhagic morbidities really top the charts in terms of SMM indicators. Next slide, please. And when this is also taken from the state of Tennessee SMM report over the most recent report from 2018 to 2022, when you look at SMM indicators, DIC, of all the ones that are listed here, DIC tops the charts. So you can see its clinical significance. Next slide, please. So what exactly is DIC? It is a consumptive coagulopathy, meaning that the clotting pathway goes completely haywire. And there's activation of clotting molecules, and then concurrently that consumes all the ones that should be circulating in the bloodstream. So then there's not enough to plug, if there's any particular tissue damage, and that activates both the, you know, intrinsic clotting pathways, the extrinsic clotting pathways. So you get these micro clots in the small vessels of the body, and that leads to basically tissue death distal from those small clots. Because the clotting factors are all consumed in those micro clots or microthrombi, then that leads not enough clotting factors other places in the body. So a patient who's in DIC might have bleeding from their IVs, from their mucous membranes, from their nose, all surgical surfaces, and it can quickly progress to what we call the triad of death, where you have acidosis, hypothermia, and coagulopathy. That is what we are wanting to avoid. That's where the death spiral comes in. That's what we're trying to avoid with DIC. Next slide, please. So when we talk about, okay, well, how do we assess someone who's in DIC? How can we even know whether or not they are in DIC? And a good starting point is really understanding the coagulation studies in pregnancy. What is normal, what is abnormal, and what, by different trimester. The liver is very active in pregnancy, so it is making a lot of clotting factors. So, particularly clotting time and bleeding time is different based on a patient who is pregnant. Additionally, fibrinogen, because of increased activity of the liver, fibrinogen increases normally. So a lot of times it's not unusual to see fibrinogens in a pregnant patient upwards of 4, 5, 600. So what would normally be, concerning in pregnancy, our threshold is a lot, um, you know, is a lot lower for concern because we expect the fibrinogen to be high. Next slide, please. And that's an early indicator of DIC. So some of the clinical and laboratory findings that one might see in DIC is uncontrolled bleeding. It's kind of a paradoxical shift because you've got I'm sorry, all of these small clots in one area in the microcirculation, and then you have conversely lots of bleeding in the other areas of the body, and that is what can lead to the microclots in the capillaries can lead to multi-organ dysfunction because of cell death. Additionally, those microclots basically can act like glue and trap the platelets. So there's lower amount of circulating platelets, and it just kind of goes into that spiral because you have lower platelets to clot the other areas of the body and then you have excess bleeding that leads to more hemorrhage and then tissue death, and then that's what leads to ultimately the demise of the patient. Next slide, please. So as we mentioned earlier, DIC is included in the Center for Disease Control's 21 SMM indicators, and it's often classified as a near miss. Next slide, please. So I think we are going to, go over, there's a lot of different reasons why a patient may be in DIC. That's a secondary manifestation of the main problem. But there are many underlying pregnancy-related conditions that can lead to DIC. Um, if you are if you're thinking of any, feel free to chat, put those in the chat. What are pregnancy specific complications that can lead to DIC or this consumptive coagulopathy? Okay. Retained products, postpartum hemorrhage, absolutely. Okay. We're going to go over about 5 clinical scenarios that could lead to DIC, talk about how the patient presented, what are some of the laboratory values that we might see, how do we manage these patients. Next slide, please. Okay, so our first case is a 36-year-old gravida 3 para 2 at 39 weeks who undergoes induction of labor. Shortly after AROM, or artificial rupture of membranes, she developed sudden dyspnea, shortness of breath, hypotension, cyanosis, and seizure activity, followed by cardiac arrest. Next slide, please. Some of the key findings that are present here are complete cardiovascular collapse and pulmonary collapse, profuse vaginal bleeding and oozing from her IV sites, thrombocytopenia, prolonged PT, fibrinogen less than 100 milligrams per deciliter, and an increased D-dimer. Next slide. So, what is the diagnosis? The first one, an amniotic fluid embolism. Key in your thoughts: pulmonary embolism, eclampsia, myocardial infarction. Not sure. Just get me out of here. Okay. Kind of gave it away. Any guesses?
Trying to click on it to make the answers pop up for us. Sorry, y'all, technology is not my friend. I have 7 people for an amniotic fluid embolism.
Okay. Any other?
No. Oh, 1 person for a placental abruption.
Okay.
And it looks like that's everybody's answered who's logged on.
Okay.
I like the last one best, Dr. Lister. Not sure, but get me out of here.
Right. Yeah, you see blood pouring out of someone's vaginal opening. That is not. But if you recognize it and you know what to do, then you may be able to help this patient. So, yes, next slide. The answer is amniotic fluid embolism. Absolutely. So the question is, what is this? What is an amniotic fluid embolism? Next slide. So that accounts for about 6% of DIC cases, and it is characterized by cardiovascular collapse, respiratory failure, and coagulopathy. The thought is that the body is having an anaphylactoid reaction to the materials in the amniotic fluid, and that sets off a cascade that leads to essentially anaphylaxis and coagulopathy. Next slide, please. The mainstay treatment is correcting the coagulopathy with transfusion of packed cells, FFP, platelets, cryoprecipitate in a 1:1 ratio, tranexamic acid, CPR, even things like ECMO has been used in certain case reports with success. Um, Resuscitative. So it's really important to deliver the fetus if it's not already delivered, and to pretty much remove the insult, correct the coagulopathy, and treat if there's evidence of right heart failure, then to treat that appropriately. You will also, there's some, you know, studies that have looked at the AOK regimen, atropine, odanzatron, ketorolac, as with successful outcomes. Amniotic fluid embolism used to be almost universally nearly fatal, but with um, um, more prompt recognition and early resuscitation, we have been able to improve the um, the outcome for those who have survived amniotic fluid embolism. I think the main thing that can kind of differentiate it from the reason why the mother may have seizures is because of brain hypoxia, and that can be differentiated from conditions like eclampsia, because instead of hypertension in the setting of eclampsia, you will likely see cardiovascular collapse, so profound hypotension. And I have unfortunately, had cases with amniotic fluid embolism. Most these are rare events. Um, these can be fatal, but with prompt, um, resuscitation, that can improve the potential outcome for these patients. So, any questions or concerns about that? Okay. And really, the resuscitative hysterotomy is kind of in the situation if you were trying to do high quality CPR for the mother and she just still does not have a return of spontaneous circulation after 4 minutes, then it's best to decompress the uterus. That makes the she can benefit from potentially that auto transfusion. There's It's a better outcome potentially for the fetus if you are able to deliver in that 4 minute window. And importantly, you do not want to transport, you don't want to waste time transporting the patient from wherever she is. So if she's in the operating room, then she should remain in the operating room. If she is outside of the operating room, it's best to perform a resuscitative hysterotomy at the bedside, because really that 4 minute window is critical to her survival and the neonate survival. Okay, next slide. Okay, case 2. We have a 29-year-old gravida 2 para 1 at 34 weeks gestation who has chronic hypertension. She presents with sudden abdominal pain, uterine rigidity, and vaginal bleeding. Next slide. So your clinical findings are painful and firm uterus. We usually kind of refer to that as like maybe a tetanic contraction where it's relatively firm. There's not really rest in between the contractions. You may see on the fetal heart tracing um, uh, late fetal decelerations, and that indicates uteroplacental insufficiency. Fibrinogen. Normally, outside of pregnancy, this may not be as alarming, but, within pregnancy, the fibrinogen, uh, generally is over 200, well over 200 milligrams per deciliter. And we have seen them as high as 500 and 600, once again, because of the liver clotting factors. The platelets, 89,000, consistent with thrombocytopenia and a prolonged PT. So are we in DIC? I would say uh, certainly we're moving toward that direction. We have a thrombocytopenia, prolonged PT, evidence of coagulopathy. Next slide, please. So what is the diagnosis? Okay.
We have 3 so far for placental abruption.
Okay. Anything else?
We are at 7 for placental abruption, nothing else.
Okay. All right. This is a sharp cohort here. Okay. That's exactly right. Excellent. You got it. Placental abruption. So next slide, please. So placental abruption accounts for 37% of DIC cases. So it's the most common cause of DIC in pregnancy. And it's characterized by abdominal pain and bleeding. and it may be accompanied with fetal heart rate changes and increased uterine activity. So essentially, the placenta should not separate from the uterine wall until after the baby is born. When that happens prior to that, then that is consistent with placental abruption. There can be, it's kind of like an 80-20 rule. So 80% of the time, placental abruptions are going to bleed. 20% of the time, they're concealed abruptions. So you cannot see them, but they are still causing, they can still have the potential to cause DIC. Essentially, it's a dilutional coagulopathy. In addition to, so you're basically bleeding, you're hemorrhaging out. So you're bleeding out all your clotting factors. And then, uh, uh, we often obtain an ultrasound, but it's actually not very sensitive in diagnosing placental abruption. About 20% of the time, you'll see it on ultrasound, 80% of the time that you won't. So it's really a clinical diagnosis. Next slide, please. And what leads to DIC in this case? Essentially, you have the consumptive coagulopathy due to um, um, dilution of clotting factors. You're bleeding into a space. You're using up all your clotting factors in that particular hemorrhage, and there's not enough circulating factors. Those platelets are being also hemorrhaged in that space, and there's not enough that is being circulating. So that can lead to both maternal and fetal death. Next slide, please. As some of the risk factors for placental abruption are probably pretty familiar to this group. The number one, if there's been a previous placental abruption, extremities of age, so really young and really old, multiparous patients, a prior C-section, if there's been a history of previous miscarriage, stillbirth, conditions like antiphospholipid antibody syndrome can predispose to placental abruption. Limited prenatal care, assisted reproductive techniques such as IVF, hypertension is a big one, and PPRON because of the shearing force of the placenta. Polyhydramnios, once again, after decompressing the uterus, that can shear the placenta from the uterus, leading to placental abruption. That's one of the things that, when you're managing someone in labor who has polyhydramnios, you want to be careful with how you do the AROM, because that can lead to placental abruption. And the maternal substance use, such as particularly the stimulants like amphetamine, cocaine use, can lead to placental abruption. Smoking is a big one. Okay, next slide, please. So, what is our management? Essentially, you want to make sure that both the mom and the baby are stable. Believe it or not, there's a lot of placental abruption by itself. There's a lot of redundancy in the placenta. So, even, up to half of it can be abrupted and this baby can still get perfusion. But if the placental abruption, threatens the stability of the mother, and leads to DIC, that is an indication for immediate delivery of the fetus in the placenta. Um, you want to, the idea is restoring the circulating volume, giving blood product administration. You want to keep the fibrinogen greater than 150 milligrams per deciliter. Next slide, please. Okay. This patient is a 24-year-old gravida 1, para-0 at 20 weeks, presents with fevers, chills, uterine tenderness, foul-smelling discharge, and hypotension. Next slide. There was a lot in that vignette. What are the thoughts in terms of, what do you believe the diagnosis is?
see what we got coming in. Okay, so far we have 5 people for sepsis. That's it as of now. Okay, 6. It's like, oh, we're at 6. So now we're at 7 for sepsis. No other options selected.
No other options. Okay. Yes. So, yes, that's certainly the fever gave it away. Um, the what we're illustrating now is that there's a lot of different ways to get to DIC. And ultimately, your goal is to collect the coagulopathy if one exists. Um, I mean, obviously one exists, to resuscitate and really identify the source and treat the source. So sepsis is the correct answer. Next slide, please. So sepsis is triggered by cytokine release that affects the endothelial leakage. It's trying to, the body's trying to do right by getting some of the cytokines and the you know, inflammatory markers into the tissue space. But unfortunately, as a result, that can lead to endothelial dysfunction, increased tissue factor, and this coagulation cascade. So ultimately, the systemic inflammation is what activates the coagulation uh, uh, cascade, and that can lead to DIC. Next slide, please. So, management of DIC in the setting of sepsis essentially is you want to identify what the underlying cause is. In pregnancy, urosepsis is very common. Pneumosepsis, septic abortion, chorioamnionitis. It actually sounds like that's what our patient had, some element of an intrauterine infection, and that can happen in the setting of PPROM, or you know um, other non-pregnancy related things that can cause sepsis are things like appendicitis and cholecystitis. Any kind of infectious etiology can lead to sepsis and ultimately lead to the same common pathway. Um, you want to do aggressive fluid resuscitation, and hemodynamic monitoring. Patients who have, sepsis and DIC are often have a condition called ARDS that can lead to respiratory compromise because the vessels in the lungs are also leaky, and that can lead to, stiffer lungs and the need for ventilatory support. So ultimately, the goal is to resuscitate kind of specifically what is low. So if the platelets are, you know, ideally over 50,000. I mean, if they're less than 50,000, you want to transfuse, especially if you're thinking about if they need surgery for any reason. You want to keep the PTT greater than 1.5. Heparin anticoagulation and antithrombi 3 treatment is debatable, but in general, patients who are in DIC are at higher risk of VTE. So that is something that we often will administer as well, is heparin anticoagulation. And then, of course, source control. So you want to administer antibiotics if it's a urosepsis or pneumosepsis type of issue. If it's resident to the uterus, you may even have to do a hysterectomy, for source control. If if you're not able to gain it in any other way with the DNC or other uterine sparing procedures, you may have to do a hysterectomy. We have done that at times for source control in the setting of severe, endometritis that does not get better with antibiotics, and if she has complications of DIC. Okay, next slide, please. So we have case 4. This is a 32-year-old gravida-4 period 3 who just delivered, experienced postpartum hemorrhage due to uterine atony after a vaginal delivery of a macrosomic infant. So just put in the chat some of her risk factors for postpartum hemorrhage, if you can. Yeah, macrosomia, certainly, because that overdistends the uterus. Things like polyhydramnios. So if she was, a patient who had diabetes, yes, multiparous patients are more likely to experience postpartum hemorrhage. Next slide, please. I think I have a slide on other. Yes, so other risk factors. So pretty much what leads risk factors for DIC in the setting of postpartum hemorrhage is severe postpartum hemorrhage. So the things that can lead to, increased risk of postpartum hemorrhage are things like cesarean birth, multiparity, some of that you guys have named. If she has a maternal coagulopathy baseline, like von Willebrand's factor, or protein CNS, uh, issues, then that can lead to excess bleeding, multiple gestations, fibroid, if she's had a prior postpartum hemorrhage, and then the intrapartum factors that we mentioned. If you have a prolonged induction or a large infant, chorioamnionitis, all of that interfere with the normal contractile ability of the uterus, and it can lead to uterine atony, which leads to postpartum hemorrhage, which can, if untreated, can ultimately lead to DIC. Next slide, please. Okay, so our etiology of DIC and postpartum hemorrhage is once again a dilutional thrombocytopenia. It's kind of twofold. So you're bleeding out all your clotting factors and your red cells and your platelets. So that understandably is going to lead to a coagulopathy. But in addition, you have hypoxia at the tissue level, which leads to tissue damage and increased risk of that intrinsic clotting pathway as well. So those can both lead to DIC. And ultimately, next slide. The management is, first of all, identifying the cause. Most common cause is uterine atony. That accounts for over 70% of hemorrhage, postpartum hemorrhage. And when I was going through my training, they were like, what's the first, second, and third? And it was like uterine atony, uterine atony, uterine atony. Like that's what you should be thinking pretty much, mostly. And then secondarily, of course, you want to evaluate the patient for obstetrical lacerations and repair, particularly the cervical laceration or deep sulcal tear. Both of those can lead to brisk bleeding and the bleeding out of clotting factors, and lead to, if not recognized and treated, that can lead to DIC. And then retained placenta can also lead to DIC as well, from postpartum hemorrhage. Next slide, please. So here are the different stages of postpartum hemorrhage, and the treatment regimen, depending on the etiology. Of course, you're going to repair any lacerations. You're going to inspect the placenta, make sure that it's intact and there's no remaining products inside the uterus. You're also going to ensure that the uterus is firm below the umbilicus immediately postpartum. And, as you get, your initial treatment is going to be aggressive management of the third stage. So that's going to be fundal massage, administering IV Pitocin, other uterine tonics like Methergin, Hemobate, Cytotec, TXA should be a part of your armamentarium. And then there's different contraindications depending on what other comorbidities you're dealing with. So for asthma, Hemobate would be contraindicated. For patient who has, cardiac disease, Methergin is, likely contraindicated. Cytotec is, a good option, but it may not act as quickly. So, your fundal massage, and then you can go to the surgical or the non-surgical management. It would be like your Bakri balloon or your vacuum device, and then your surgical management would be, compression sutures, B. Lynch sutures. O'Leary, ligating the uterine artery, and ultimately hysterectomy if you're not able to control the bleeding. So those are things that should, really be automatic, and ultimately so that you can prevent that triad of death. You want to prevent, the coagulopathy. You want to stay ahead of that, replace factors. You want to prevent acidosis, and then hypothermia. So, while you're managing a hemorrhage or any kind of concern for DIC, you want to make sure that the room is nice and warm. So just like our neonatal colleagues like the room to be really warm because they want to prevent hypothermia in the neonate, because that can cause, issues with clotting. In the neonate, we want to keep the room nice and warm for mom. We can, drop her temperature if we have blood coming from the blood bank that's cold, and you have ice cold fluids going into her, her veins, and then the evaporative losses with an open abdomen. All of those things, it's when you're kind of in the midst of the, the activity, it, may be hard to kind of remember all of that, but your anesthesia colleagues and you want to be always thinking about, is the patient warm? Are our fluids warm? Are we trying to prevent coagulopathy? Because the clotting cascade just gets worse in the setting of hypothermia as well. Okay, next slide, please. Okay, so we kind of went through the treatment. I kind of went through all of the active transfusion, and sometimes it can be tempting. Before patient, um, um, a mother can kind of compensate really well before she has hemodynamic collapse. So you want to really replace what is lost. You don't necessarily have to wait for labs to know whether or not patient needs to be transfused. If she is bleeding profusely, if her, the blood in the field is not clotting, that's a pretty good indication that she is, going into DIC, and she needs to be, um, replaced at the level that she's losing. So you don't want to necessarily wait for a complete tanking of her vital signs before you begin your resuscitation, because you don't want to get behind. Okay, next slide, please. Okay, this is, I believe, our last case. This is a 32-year-old Gravida 2 Para 1 at 33 weeks and 4 days gestation, presented to labor and delivery with a 24-hour history of a severe frontal headache, visual disturbances, and epigastric pain. Her prenatal course was notable for inconsistent prenatal care, no prior diagnosis of hypertension. On arrival, her vital signs revealed a blood pressure of 186 over 118 milligrams per mercury, heart rate of 112, respiratory rate of 20, O2 saturation 98% on room air. Physical exam demonstrated hyperreflexia with 3+ deep tendon reflexes and clonus. Fetal monitoring revealed a category 2 tracing and intermittent late decelerations. Next slide, please. So you can see her platelet count. She's consistent with thrombocytopenia. Her AST and ALT are both mildly elevated. Her LDH, which is a marker of hemolysis, is increased to 680. Her serum creatinine is 1.4. Her protein creatinine ratio is also elevated at 4.2. Next slide, please. So 2 hours later, the patient had a generalized tonic-clonic seizure consistent with eclampsia, despite airway support and additional magnesium sulfate. Next slide, please. Okay, so ultimately, she was discovered through the hospital-based prevention strategies. And then, actually, I think the slide is a little bit out of place. I'm sorry. Can you go to the next slide, please? Okay, next slide, please. Okay. Next slide, please. Okay, so she ultimately underwent delivery in the operating room. Uh, you can see by her labs, her platelet count is 42, so it's gone lower. Her fibrinogen is 95. The INR is 2.1. The D dimer is elevated. Her PGT is markedly elevated. Next slide, please. So what is the diagnosis? I think I said it earlier, but go ahead and key it in.
Okay. We have 1 for sepsis, 2 for eclampsia, and 2 for placental abruption so far.
Okay. All right. So this patient suffered an eclamptic seizure. So she has eclampsia and she has DIC related to that. Next slide, please. Yes. Okay, so the pathophysiology of DIC in the setting of preeclampsia. You have endothelial dysfunction. So the placenta does not marry the maternal vascular surface as well. There's like incomplete union between the placental vessels and the maternal blood vessels. So that leads to like local ischemia at the level of the placenta and hypoxia. That releases anti-angiogenic factors such as SFLT and inflammation. And then that leads to those kind of like, reactive oxygen species can lead to endothelial cell damage. And once again, that increases tissue factor. And that's what activates the coagulation cascade and leads to the DIC related to in the setting of preeclampsia, eclampsia. Next slide, please. So the treatment ultimately is stabilization of the mother. And, there are certain cases like where, you know, um, sometimes there may be a hesitation to take a patient to the operating room who is quote unquote unstable. Um, I would say in the setting of eclampsia, yes, you want to make sure that your blood pressure is controlled or, relatively stable. You want to make sure that, that she's hemodynamically stable before you cut into her belly. But in cases like abruption, where someone's actively bleeding or amniotic fluid embolism, that patient is also, you know, very unstable. But part of the stabilization is removing the fetus. So, so kind of have in your mind that what is going to be required to stabilize this patient, and even if her vitals are not stable right now, if I wait, then they're going to become more unstable, and really the stabilization is to remove the fetus from the fetus and the placenta. Whereas in the case of of eclampsia, you want to make sure that her blood pressure is controlled. You don't want to take her. She could be coagulopathic, and you wouldn't know that unless you monitored her laboratory. That's going to make an impact with what kind of anesthesia she's going to be able to get. Like if she's In DIC and coagulopathic, she's not going to be a candidate for regional anesthesia. She's going to have a general anesthesia. So those are the kind of things that you want to monitor prior, as you think about what kind of surgical planning you want to do. You don't want to just take someone right off the street who's just had an eclamptic seizure and rush them into the operating room, because you got to know, where her coagulation status is prior to that, in that planning. Okay, next slide, please. So, yeah, just to conclude, DIC is really a secondary systemic process characterized by widespread activation of the coagulation cascade, leading to consumption of platelets and clotting factors. This ultimately leads to microvascular thrombosis, and then paradoxically bleeding in other areas. And it's a common SMM indicator and associated with increased mortality. The main thing is really identifying the underlying cause that's causing the DIC, and then treat that. That's central to the proper management. And ultimately, if we treat the underlying cause, correct the coagulopathy, patients have a much better chance of surviving a DIC, event. I think that is it. I'm happy to take questions.
Thank you so much, Dr. Lister. Does anyone have any questions? If you're not able to come off mute, you can also add it to the chat. Looks like no questions, but we got some thank yous, Dr. Lister. All right, so we will go ahead and now close this out if that's all right with everybody. So just a few announcements. We do still have a few webinars upcoming. We have our Heart Month webinars, which are on building a multidisciplinary care team on February 6th and effective patient event debriefs on February 20th. We are looking at doing our next SMM webinar either in April or May of this year after our annual meeting. Speaking of annual meeting, if you have not registered, please go ahead and register. We do have a very fun event planned. It's going to be jam-packed. On Tuesday night, we are doing a film screening. So if you just want to scan that QR code, you'll be able to get more details and get registered, and also go ahead and book a room if you have not done so yet. I hear that they are filling up quickly. And then also we will be having another advanced quality improvement boot camp. This is for anyone who just has a baseline knowledge of QI and they want to build and expand on that. If you scan that QR code, it will take you to our event registration for that. It'll be on April 22nd from 8 a.m. to 12 p.m. Central Time at VUMC's 100 Oaks located in Nashville. And then we also have our post-event survey. If you don't care to scan that QR code, it'll take you straight to a survey. Let us know how we did today, if there's any cases that you would like to see reviewed or anything covered, and we'd be happy to do so. And thank you all so much for your time today. And thank you, Dr. Lister.
Thank you. My pleasure. Bye.